Good afternoon, and welcome to our webinar. Today's topic is on the opioid crisis in America and what it means to individuals experiencing homelessness and SOAR applicants which we serve, and those who provide treatment and supportive services to SOAR applicants. My name is Pam Hine, Senior Project Associate with the SOAR TA Center, and I will be moderating today's event. Today's welcome is Robert Grace, SOAR Project Officer with the Homeless Branch with Center for Mental Health Services in Rockville, Maryland. Bobby? For Bobby, so he can provide the welcome today.
Thanks very much. I appreciate it. And thank you all for joining us today. I'm Bobby Grace, and on behalf of the Substance Abuse and Mental Services Administration, the Center for Mental Health Services Homeless Programs Branch, I would like to welcome to this SSDI Outreach, Access, and Recovery webinar called Understanding Opioids and Other Drugs. How it impacts patients, states, and communities, increase access to Social Security disability benefit for eligible adults who are experiencing or at risk of homelessness and have a serious impairment and or occurring substance use disorder. Webinar will focus on the opioid crisis in the United States in the context of people with disabilities who are experiencing or risk of homelessness. We know that opioids have significantly impacted this vulnerable population. To address this crisis, the U.S. Department of Health and Human Services has ordered an additional funding of $144.1 million in grants and to treat opioid addiction, which are SAMHSA. I'd like to welcome and thank our presenters for Dr. Hyler Gray, who is the Director of Healthcare for the Homeless in Baltimore. Next, we have with us Long, who is the Director of Housing with Mountain Comprehensive Care Center in Prestonburg, Kentucky. And round out our presentation, we have Mr. Stephen Samra, Deputy with Nebraska in Massachusetts, for you to share your expertise with us. So further or delay, I will turn it back to Pam Hine, who will be moderating today's webinar. Pam?
Thank you. Thanks so much, Bobby, for your support of this webinar. So just housekeeping items before we begin. Just a disclaimer. Training is supported by SAMHSA and DHHS. The contents of this presentation do not necessarily reflect the views or policies of SAMHSA or DHHS. The training should not be considered substitutes for individualized care and treatment decisions. And if your webinar instructions, which will help you enjoy this event. You'll be muted throughout the webinar, and this webinar is being recorded and will be available for download on the SOAR website in about a week. You download now the presentation slides and handouts by going to the top left of your screen, clicking on the icon File, then Save, and then Document to download the materials, or you can go to the SOAR website, which you saw in our title slide. You can also will also be connected to a brief evaluation at the conclusion of the webinar, which we ask that you complete. And finally, we will save all questions and comments until the end of the presentations, at which time we will review instructions for asking questions via our chat function. A few of the learning objectives. So it's our intention that by the end of this webinar, you will have a better understanding of the opioid crisis, both nationally and, in the Kentucky and Maryland areas. And you'll have a better idea about its abuse and misuse amongst people experiencing homelessness and some of the national trends. And you'll have a better understanding of the clinical consequences of addiction to opioids and really the differences between prescribed treatment and addiction. About the importance of peer supports with engaging and providing services to individuals with opioid use and misuse, and also improve your knowledge overall of the signs of opioid addiction and related treatments and support services to better serve SOAR applicants. So, as Bobby mentioned, for the agenda today, you'll first be hearing from Dr. Gray, who will provide a clinical perspective. Then we'll hear from Jackie who is in eastern Kentucky, and talk a little bit about the opioid crisis there and the housing supports and treatment available in eastern Kentucky. And then we'll round things off with hearing from Steve Samra, who is with Brass Tacks, who will provide a peer perspective on medication-assisted treatment. And then again, we will throw it back to you for some questions and comments. So without further ado, I'd like to turn it over to Dr. Tyler Gray to begin his presentation. Dr. Gray?
Good, everyone. My name is Dr. Gray. I'm the medical director with Healthcare for the Homeless. We have a few different clinics, and I work in West Baltimore. So let's get started. So my disclaimer is that I'm a family physician. I work in primary care. I do have a strong interest in addiction. I do not have any specialty training. I'm not an addiction psychiatrist, but I do have a fair amount of experience with this, and I have no financial disclosures. So kind of what I'm going to go through, I'm going to start out with a case study just to kind of frame this discussion, a brief review of some of the statistics of our current epidemic. We'll go through definitions, we'll talk about medication-assisted treatment, and kind of review treatment strategies in general. And Stephen is going to talk some more about those later as well. So I'm going to read this slide to get us on the same page. So this is a patient of mine, FJ. She's a 42-year-old woman. She has AIDS, hepatitis C, and major depression. She comes in and asks for help with her heroin and cocaine problem. She asks for and decides to start on Suboxone, which is Buprenorphine Treatment. She asks to come in every 1 or 2 weeks, which she does for a period of time. She says that during this time she goes to NIDA meetings a few times each week. She's here and there and is kind of vague about that. Sometimes stays with her parents. She frequently misses appointments and then will come in a few days later, saying that she's out of medication and relapsed. Her urine drug screens are always positive for heroin and cocaine, and also is not consistent with taking her HIV medication. So our team had tried to get her into a more structured drug treatment program, and she did get to a couple of these, escorted by our outreach team. Each time she left those programs within a couple weeks, we kicked out for not following the rules of either the housing or was kicked out relapse. So then it comes back to us. So a lot we could talk about with this case, but I suspect that many of us on the call have seen someone face some of these challenges. So it's in Maryland, and I used the Maryland statistics over the national ones because I could find more up-to-date numbers. Because really the numbers have changed quite a bit in the last couple of years. So don't worry quite so much about the numbers because, again, this is just unique to state, but there's 3 graphs here, and take a look at the difference in the trends. This first one is the number of prescription opioid-related deaths. So this is medications like oxycodone, Percocet, morphine. So they've increased. Heroin-related deaths in Maryland over this time, you can see that the numbers have gone up quite a bit more and have more than doubled since 2014. One of the players that has driven the recently has been fentanyl, which we're going to talk more about in a second. So this graph, you can see fentanyl has always been around causing overdoses in radio folks, and recently it's really exploded. I believe this is a trend not just in Maryland, but throughout the country. So I would like to spend a moment on fentanyl because many of you may have heard of it and wonder what it is. So sure, I think it's a bit dramatic, but it does get the point across that fentanyl does essentially the same thing as heroin does in the body, and it's quite a bit more potent. So it's tough to put all these numbers down, but one way to think about it is that so as a opiate that we used to compare a lot of things to. So heroin is about 4 to 5 times stronger than morphine. Fentanyl is about 20 times stronger than heroin. So you might hear stats like fentanyl 100 times stronger than morphine, which is true. And you might have heard of something called carfentanil, which is a derivative of fentanyl, and that's about 100 to 1,000 times stronger than fentanyl itself. So the chance that it takes very, very small amounts of fentanyl or carfentanil to potentially cause an overdose. So I don't have about why this is ending up in the drug supply. Certainly it makes the high stronger and faster, and more along the production chain this is getting put in there. But obviously no one's with the precision needed, so some batches come out on the heroin, on the fentanyl, and those lead to these spot overdoses that many of us have seen. Definitions. So I was thinking about this. I think a good analogy when we talk about these medical definitions is to think about caffeine. So I, like many of us on the call, am dependent on caffeine. So you can see the third bullet point, dependence, is being sort of a circular argument, but being dependent on a substance. So really what that means is that tolerance develops. So you get used to a certain dose of a substance. So with caffeine, we found that if you've never had coffee before, you drink a cup of coffee and you feel a bit wired, you have a hard time sleeping, but you have that cup every day for a while, all of this one cup doesn't do so much for you, and to get that same effect you would need multiple cups. So that's a description of tolerance. Withdrawal are symptoms caused when habitual use suddenly ends. So caffeine withdrawal headaches, as many of us probably do. Every substance that can produce tolerance and withdrawal has a different set of symptoms associated with it. It's really key to think about the difference between dependence and addiction. I add on here that these terms are actually not used in the DSM-5. That stands for Diagnostic and Statistical Manual, version 5, which is the kind of the goal of psychologic diagnosis. And they no longer use those terms. I'll get to what we currently use in a moment. But they're terms that are used colloquially quite a bit. And the main difference is that dependence justifies a state where someone gets tolerance and withdrawal symptoms from a substance, whereas addiction implies a lot of maladaptive features, such as some of the features of the slide. So the current terms for any substance is substance use disorder. And then down the bottom right of this slide, we label that or modify that being mild, moderate, or severe, and we like to specify which substance. So these 11 criteria, if you'd apologize my shorthand, each of them are a little bit long, shorthand to kind of get a sense for some of the criteria that you need to meet in order to get diagnosed with a substance use disorder. The few I'll point out are numbers 5 and 6, which really suggests that not just that someone is using something and getting withdrawal symptoms, but that they're having problems in their lives in their work and their social life, or number 8 and 9, using in hazardous situations or using despite medical problems. These are really the hallmarks of when a substance use disorder really becomes problematic. And so I'd say that for most of us, maybe dependent on caffeine, we probably are not perhaps willing to meet our obligations or using hazardous situations, and therefore would not meet the criteria for substance use disorder or addiction. Note about co-occurring disorders. Co-occurring disorder is describing someone who has both a serious mental illness and a substance use disorder. And the quote here is from the SAMHSA website. The link to the bottom. There's a lot more information on the website for those who are interested. In cases, people receive treatment for one disorder while the other disorder remains untreated. And really what this gets to the fact that while there are some similarities in terms of the brain chemistry that can involve in substance use disorders and mental health disorders, there are unique diseases. And to really get at properly treating someone, we have to take all of these into account. So as a doctor and primary care doctor, I need to take into account the medical conditions, the mental health conditions, and the substance use conditions. If we ignore any of those, we find that we make a lot of progress. Just a list of some of the signs or symptoms of use disorder. So on the left, kind of descriptions of intoxication, and on the right are symptoms of withdrawal, which patients often describe as feeling dope sick. I was going to find some pictures, but the pictures were all a bit group for these. I'll read through all of these, but I'm happy to answer questions about them more later. But intoxication obviously is what leads to overdose and death, and that happens through someone's breathing slowing down so much that they don't get enough oxygen in. So things really changed in terms of our understanding of addiction over the last decade or so is really have come to view addiction as a chronic brain disease as opposed to a problem of willpower. So the first bullet point, dopamine. Dopamine is a chemical that's in all of our brains. It's very important in the brain's reward pathway. It means anytime any experience something which is rewarding, our brains get flooded with dopamine, and this produces in some cases a state of euphoria, but in other cases just it can produce happiness, and that's what our brain uses to tell us, oh, that made me feel good, I should do that again sometime. And with the drug, it really hijacks the system, and the levels of dopamine are quite high, and the brain never forgets that. This is a generalization, of course, but with ongoing use, with many of these substances of abuse, tolerance to withdrawal develops. So, at first, the dopamine produces the positive effects, and then one finds that, hey, when I don't use, now I'm starting to feel sick. And, man, when I used to, drugs I would get for $10, I would for a day or two. Now it's only lasting me hours, and I need to spend more and more money. So those are all signs of tolerance and withdrawal developing. And people's social lives start revolving around the drugs, and people can develop and compulsive use and find themselves in a situation where they're using simply to avoid withdrawal and to try to get that dopamine level back somewhere near normal. Talk to people who have had a long-term substance use disorder, but they're using to even try to get high. They're just trying to feel normal, and that's oftentimes what happens. The bottom is that stress, behaviors, and the social context of initial use, such as being in a neighborhood where you were passed, can lead to relapse after years without opioids. And again, I just go back to this dopamine rush and the imprint that leaves on your brain, that even if it's out of your mind, that's in the primitive part of our brain, and then come back and lead to relapse. So these are a list of some consequences of opioid use disorder. The main ones that I think about: HIV, hepatitis B and C, and infections. Are, I'm sure, quite familiar with the social consequences: incarceration, unemployment, loss of family support, and obviously overdose. This is kind of a menu of treatment options. Probably a lot of different opinions if you ask different doctors or addiction counselors about what treatment entails. But one I think about it is there's a lot of possibilities, and we mix and match our interventions to meet the patient's needs. So it can involve self-help groups like NA or AA or Life Ring. It can involve one psychological interventions. It can involve group interventions or community-level interventions. From Methadone, it can involve a detox, which is using medications to get someone through the withdrawal period so that they're no longer dependent on a medication or a drug. It can involve medication-assisted treatment, which I'll talk about more in a moment. It can involve intensive outpatient treatment or inpatient residential. So we'll hear more about these, but I like to talk about a behavioral component of treatment and a medication component of treatment. And you know, some patients only get one or the other, and some patients get both. Most is determined by the specific treatment program, but as they're not necessarily affiliated with the treatment program, I like to look at it individually and see what their needs are. So on the left here, I listed 4 medications that I thought a lot when I think about opioid addiction treatment. So methadone, buprenorphine, naloxone, and naltrexone. So I just want to spend a minute talking about how these medications are all different and briefly on how we utilize them. So methadone, I'm sure everyone has heard of before. Medical term is it's a full opioid agonist. This means that higher the dose of methadone that gets in someone's body, the more it's a effect or additive effect in the same parts of the brain where morphine or Percocet or heroin would, and is used clinically in a methadone clinic setting to replace opioids, and we're going to get to that in a moment. Buprenorphine goes by a lot of different names. It goes by Suboxone, Bunavail, Zubsolv, and it's co-formulated with naloxone, which is the medication right below there. Buprenorphine does exist on its own, and really what that comes down to is that it's safer medication than methadone. If the doses get high enough, someone can overdose on it, just like off of heroin. It's much harder to overdose off buprenorphine because that partial effect means that with higher doses, at some point the effect actually levels off. And that gives it a better safety profile, which means that we are more comfortable giving people a supply of this to take home, as opposed to methadone, where it's very tightly controlled. Naloxone goes by the brand name Narcan. This is, you've heard about in the news as our opioid reversal drug, our overdose reversal drug. So the thing that EMTs carry out. I would encourage anyone who my situation where you come across someone who's overdosed to have this with you, and can be administered in a variety of different ways. Most commonly in an nasal spray, or in a intramuscular injection. This quickly reverses overdoses, but it doesn't last very long. The challenge with naloxone now is that it doesn't work quite as well against the drugs like fentanyl or carfentanil. So people are finding that whereas in the past 1 dose or 2 doses might revive someone, now it's oftentimes taking more than that, and sometimes the Narcan actually isn't working, which is a little bit scary. Naltrexone is used to treat is a chronic treatment. It's not used in the reversal of overdoses, and it comes in a shot called Vivitrol, which is once a month, or in a daily pill. And we use to treat actually alcohol dependence and opioid use disorder for people who do not want to be on a medication such as methadone or buprenorphine. treating an opiate use disorder with an opiate, such as buprenorphine methadone, sounds counterintuitive. And my patients, as I'm counseling them about this, they say, "Wait a minute, I didn't think Suboxone was an opiate. I thought it was something different." It is an opiate, just like morphine, Percocet, or heroin. But that's precisely why it works. Really, what we're trying to do is reduce the harm of the illicit use. So if someone's injecting, we want to make sure they have clean injection equipment so they don't get infections. We want to prevent overdoses so that someone can live to get to a point where they can, on the rest of their lives and hopefully move on from the drug use. So think about minimize the harms of the drug use. I'm not sure the evidence or science that has kind of backed this up, but for both buprenorphine and methadone, there are many studies showing that a lot of outcomes, such as health outcomes, such as overdose, HIV, and others, are significantly improved when someone is on the treatment. But importantly, medicine like methadone or Suboxone actually is continuing the body's dependence on the opioid. One way to think about this is if that dependence is this daily need for something, rather than trying to get rid of that need, I haven't really found a good way to do at this point. We substitute that with something that's safe. So rather than someone having to inject heroin multiple times a day and risking overdose, they take methadone or Suboxone once a day. And for opiates for the day is satisfied, and people find that at that point they can go to work, they can feel normal and carry on with their lives. Over time, the brain can kind of return to its pre-addiction in terms of not needing any opiate, but for a lot of that takes quite some time. What I hear a lot from patients is that, well, I'm just trading one addiction for another. And this is always a tough one to hear because it's really how I think about things. So if you think back to when we talked about what depends on addiction, addiction means that you're putting yourself in dangerous situations, you're meeting your family or job needs, requires a situation where someone's not functioning well in society, and that's because of that drug use. And I would argue that that are on methadone or Suboxone treatment and abide by the treatment expectations, that none of those things exist, and it's pure dependence. So I say that it is not treating one addiction for another. So I want a couple of quotes from some treatment guidelines, which I found very helpful to me. So this first one is from NIDA, called Principles of Addiction Treatment. I'll read this one. Detoxification alone does not address the psychological, social, and behavioral problems associated with addiction, and therefore does not typically produce long-lasting behavioral changes necessary for recovery, assessment, and referral to drug treatment treatment. So put this in just to point that what detoxification does, or detox, has a role for a number of people in their treatment in terms of getting them started on treatment. It should not be seen as a treatment for any substance use disorder. If the detox then leads into a longer-term treatment, which can involve medications, can involve behavioral treatments, or anything else, it's a great, but it alone not sufficient and is not considered treatment. These last few quotes are from the Healthcare for the Homeless Clinicians Network adapted guidelines, and I have links to these on the next slide. Most of you can read these. The few that I wanted to point out, though, that the overall benefits of continuing medication-assisted treatment and potential harms. So something, well, such as my patient, my case example, well, she's not really about rules. Shouldn't we stop her prescription? We just always weigh the potential risks to someone to stopping the prescription, such as increasing her risk for overdose, with trying to see what are the harms of continuing, and that's a challenging situation to address for everyone. And the last one I put in bold, that housing should be a component of any treatment strategy to manage opioid use disorder. that there's well-established evidence that they'll have a stable place to live. Their use tends to improve, and trying to treat addiction in the absence of a stable housing situation is near impossible. Hear more about that in a moment, and that concludes my. These are the references that I used. Thank you.
Very much, Dr. Gray. Your presentation will be a really great foundation for the second part of our webinar series, which will be next week, when we have the Social Security Administration on the line, and folks will better understand, what the signs are and some of the symptoms and treatment for opioid use. So again, thank you so much for your great presentation. And again, links that Dr. Gray provided some great links on his last slide, so I encourage you to take a look and dig a little bit deeper. So next we're going to hear from Jackie Long from Eastern Kentucky, who will share how housing and treatment is really critical to providing supportive services to the folks in her area. So I'm going to hand it over now to Jackie. We'll share what's going on in Eastern Kentucky. Thank you so much, Jackie.
Thank you. My name is Jackie Long, and I am the Director of Housing and Grants for Mountain Comprehensive Care Center, which is in Prestonsburg, Kentucky, which is in Fort County in the Bindi region. In that role, I manage our grant portfolio, which is about $15 million in grants, and also I develop and manage all our housing and any project that's construction that involves the grants. There we go. So a little bit about Mountain Comprehensive Care. We are a community mental health center. We provide a whole multitude of behavioral services and mental health services. We're located in the Big Sandy region, which is the counties that are highlighted in yellow, but we also have done a huge expansion over the last couple of years. So every county in Kentucky that has a red dot on it is somewhere we have an actual physical presence now. So region, we have had a very well-publicized substance use problem for many years. And right now, prescription opioids are the overwhelming drug of choice in our region. That contrasts with some other regions in the state where heroin is a huge problem, as well as fentanyl. But for a reason, in our area, it is prescription drugs. And while that with the Medicaid expansion, everyone has insurance and the prescriptions are more available, what we see is that overprescription is the problem associated with it. Started well before the Medicaid expansion, but overprescription is really what we see that is putting on the street and making them really available. Just an example, my friend just had hip surgery in April, and she left the hospital with a narcotic painkiller that they gave her, I think, 60 pills and a refill of that, and she didn't even nearly use her first prescription of it. And then she just had to have another surgery on her hip, and she left with 120 this time with a refill. So when it's overprescribed like that, it's very easy for those extra pills that don't get used to end up on the streets because they have a great cash value. And when you look at that in conjunction with the economic depression that we have in Kentucky, especially in Eastern Kentucky, where unemployment rates are double the national average, then you can see how that creates a huge problem. And although the state has tried to correct that somewhat with legislation, what's happened is the prescribers, some are overprescribing now because the work is intensive if they give another prescription, so it's easier to prescription and tack on refill than it is to do the paperwork for the original prescription. So the 2016 Kentucky Department of Drug Control Policy Overdose Fatality Report shows that Kentucky resident drug overdose deaths for Floyd County alone for 2012 to 2016 was 46.67 deaths per 100,000. That's deaths, not overdose incidents. Even in Kentucky, we see in some of these death rates 3 times the national average. More interesting is I just recently did some research, and Paducah in McCracken County, which is down here way in the western corner, that has now been to the top 5. They're kind of flummoxed on why that has happened. It's usually, Kentucky is associated with all those deaths, but it's thought that Missouri is a lot laxer regulations and laws on prescriptions than we do, and that it's coming across the border from Missouri and into Paducah because it's just across the river. So, heroin is not a real issue in the Sandy region, as illustrated by the 0 heroin deaths for Floyd County. Heroin and fentanyl are a serious problem in the state. I personally live in Lexington, which is of Prestonsburg, and it's about an hour and 45 minutes away. It's situated right on I-75, so Lexington gets the benefit, if you will, of the drugs that move north-south between Michigan and Florida, and a lot of off here, and we think that's why the heroin here. So in the Biggie region, we don't have an interstate. We have a parkway that runs between Lexington and Prestonsburg, but it's not for trafficking of drugs like that, and so access is limited to the heroin just because of traffic reasons. And gabapentin has become one of the most abused substances in Kentucky. I've seen that recently in housing. I've had a complaint in our apartments of someone selling gabapentin, and again, that was probably this person's personal portion of gabapentin that they're selling. And the effects that you see in the Big Sandy region as evident. I think this picture shows downtown Prestonsburg, which is a cute little town. It's clean. You don't see people, sitting on park benches and sleeping on park benches. The homeless population, where there is quite a number of homeless there, is in the most part. And it is in Prestonsburg the effects of drug use. In Prestonsburg, it's just the economy is as bad as in other areas of eastern Kentucky, but it's not affecting outwardly the town as much. It affects our economic development, though. We still have high rates of unemployment. That contrasts, though, with Wheelwright, which is also in Floyd County. This is what Wheelwright used to look like. The town, as you can see, has a secluded nature. It's in a valley between the mountains, or a holler, if you will, and it was a town that was created by a coal company, and it used to be a really big town. But then the coal boom busted, and now Wheelwright is just a shell of its former self, and it is severely affected by the epidemic of substance abuse, and it's tied directly to economic reasons here. There isn't an economic opportunity in Wheelwright, and you can walk down the street at any given time there, and if you're approached by someone, you will encounter at least someone who is under the influence of a prescription drug that will not prescribe to them. I have just finished up a project in Wheelwright, and I've traveled this road a lot, and I mean, on any given day, arrests and drug-related arrests all up and down this road that's pictured here. The big building on the left side is with a dance hall in alley, and was, part of the boom times of Wheelwright, and that had to be recently taken down because there were many juveniles going in the building. The city was afraid, and the juveniles, it was of the substance abuse problem in the community and juvenile usage, and we're going in there to buy drugs, and so the city ended up having to take big, beautiful historic buildings that they couldn't get restored. So overall, the impacts in our area are similar to other areas. There's an increase in petty crime. It used to be a place where you can leave in your car and leave your keys in the ignition and go into the store and come out, it would still be there. That's not the case anymore. Everything has to be locked. We're overcrowded. Families have been greatly impacted. There's one in the area who hasn't somehow been touched by the substance use epidemic. There's increases in domestic violence. There's increases in homelessness. We have children who are removed from homes, and then in other situations, children who are basically the parents and acting as the parent in the home. It is a severe strain on economic development in the area of region-wide. I'm focusing mostly on Floyd County today, but entire region, it's all a similar story. The lack of a sober workforce has really made it hard to attract new economies. It's hard to develop an economy. I have people who have interviewed that I couldn't hire because they couldn't pass a drug test. I've had people that in the middle of the interview literally fell asleep with chin to chest, falling asleep in the interview. So it is a huge issue, and it's hard to attract companies to come there. Have the problem of terrain. That's very hard to find a place to build a factory or something like that, and then pulled with a sober workforce, it really dampens the effects. The problem is so severe that the Big C Area Development District, our strategic plan over the last several years, has said that the need for treatment beds has to be addressed in order for economic growth in the region. If there's no economic growth and jobs for people, it kind of becomes a just cycle of dependency on drugs and being able to break that cycle. substantive care is doing everything to address the problem in our region. We are providing residential treatment. We have a Center for Recovery and Hope that just recently opened in the last year. It has 60 beds for men and women, so 30 of each. We recently opened the Serenity House, which has 10 beds of treatment for women who are pregnant. They also bring their children to the Serenity House with them after they have had the child, so they can start parenting classes and learn to take care of the child before they go out on their own, finish their substance use their treatment. We have Homeless Veterans Transitional Housing Center, which is also used as a treatment center. So when our veterans come there, if they have a substance abuse disorder, they can also receive treatment there while they're in transitional housing. Developing a men's treatment center in Paducah, which will be a 16-bed center. Also, I forgot on the slide, we just opened in the last couple months another women's treatment center in Western Kentucky in Owensboro. It's 16 beds. We also outpatient treatment through all of our clinics statewide. We close the drug courts in our region, in our region, and we offer school-based programming statewide. In fact, school programming is we started with our expansion. You can get funding for programs for substance abuse disorders through many resources. They vary nationwide. For housing, path resources in Kentucky, we have to access that through the state, and I think that is pretty uniform across the nation. Brands that currently have just for substance abuse, the Responsible Fatherhood Grant focuses on incarcerated men, and we also have the SAMHSA, where we did have we've completed it now, the SAMHSA Adult Offender Reentry Program. That's a residential treatment for pregnant and postpartum women program, which is for our Serenity House. We have our Substance Abuse and Mental Health Services and Treatment Grant, which is in our Healthcare for the Homeless Clinic. A Primary and Behavioral Health Integration Program, which is a new grant we just got, that also houses our Healthcare for the Homeless Clinic. Seeing the housing problem because that is really, as we said, essential to recovery. In our area, we have a housing problem, and many people who come out of our residential treatment have nowhere to go. They're homeless when they come in, or they don't have a sober place to go back to. And if you can't go back into a sober situation, it's really hard to maintain your recovery. We're innovative about additional thing because the housing situation is in our area. So we develop transitional housing that can people come out of the mountain center and go into housing where they can they can live until they can get a voucher for housing and continue their treatment while they're there, reunited with their children, and find jobs and prepare themselves to go back into permanent housing, because sometimes really when you're released from treatment, you're not ready to make that jump right back into the real world, and having a transition is better. The problem, of course, is always resources to produce something like this. Resources are limited, but everyone can access Federal Home Loan Bank funds wherever you're at. There are regional Federal Home Loan Bank in the states of you. although the rules for their affordable housing programs are different in every region for the Federal Home Loan Bank, they all have programs that would be accessible and you could use for transitional housing or permanent housing for people who have a substance abuse issue. In the Cincinnati region, we can actually awarded a grant of up to $1 million per project and have access to those funds many times over. In fact, they're in our Mountain Center for Recovery and Hope, but is a major player in the affordable housing for construction resources. State housing agencies will usually have some funding. It's different from state to state. We're lucky in Kentucky that we have an affordable housing trust fund. Our state housing agency also administers the home funds and also the income housing tax credit. So those are all sources that you can put in to reduce the amount of debt, and only having a no debt project, which is one. If you can do a no debt project, that allows you so much more flexibility in the programming that you do. You can also use the continued care permanent housing bonus, especially if you have a large population of chronically homeless people that you're serving. Foundations is a great place to look for funding. It is usually regionally to access local corporations, because they will usually have some kind of foundation that caters to only to regions where they do business. So that times, if you can look those people, make a relationship with them, you can oftentimes get funding from that you can use for your housing and construction. Assistance is a huge issue in our area. I think issue nationwide, actually. We have enough available rental assistance. Our housing authorities have very long wait lists. One housing authority recently closed their waiting list because it's 3 years long. That's for housing choice vouchers. That doesn't even count their units. So again, choice vouchers are something that you can use if you can access them. We apply for our own rental assistance because of the lack of housing vouchers. So a lot of the resources like the rental assistance, solutions grants, rental assistance sources like that can help you to get your get you into temporary seats where they can have their housing paid for until a voucher comes available. First is really important when you're thinking about people coming out of because they are heavier with the housing authorities, and probably the best thing to do is have a dialogue with them to those barriers. But certainly you need to increase your people's while they're in housing so that they can get a better up on trying to maintain their housing. And I've listed some here that you can do to help people increase their income and through your management, so they can maintain their housing and remain recovery. And to turn it back over now.
Thanks, Jackie, for sharing not only what's going on in Eastern Kentucky, but also about your comment on Medicaid expansion. That may be more of a coincidence that there's an increase in, the opioid crisis and a correlation with Medicaid expansion. So I think that'd be helpful for folks in other areas of the country, and also the tremendous amount of resources you're sharing with everybody. So I'm going to hand it over to our last presenter, who is Stephen Samra with SAMHSA's Brass Tacks, who's going to give a peer perspective and talk a little bit about medication-assisted treatment. So I'm going to hand it over to Stephen.
Pam, and thank you. And I would always be happy to take on that Dr. Gray's title as well. So, and folks, today, a big thanks to SAMHSA, to Government Projects Officer Bobby Grace, and of course, Policy Research Associates for their timeliness on a really important webinar. And a huge thanks again to both Dr. Gray and Jackie Long for excellent presentations today. There is some really important information that's been disseminated, so I hope that you found some value in that. As we move through this presentation, an overview of the various treatment options that are available to us around substance use and misuse. But before we dive into that, it really behooves us to understand a critical issue facing us as we wrestle for now in the middle of the worst drug crisis that the country may have ever seen, with the choice in how to provide effective treatment to those suffering from substance use disorders. From this slide, what drives a substance use disorder is a complex set of variables at both nature and nurture, with each person experiencing it unique. As such, it's really clear that a cookie-cutter approach, this sort of one-size-fits-all approach, simply will not work. And I think that's been proven over and over again over the last 20 or 30 years now. Curious about truly having a substantial impact on supporting and treating individuals experiencing substance use disorders, we need to approach this challenge holistically. We need to do that by recognizing it's not just the addiction that is creating the challenge. We need to understand that in many cases, these factors may in fact be driving the compulsion to use. And if we ignore them, we have critical factors in their potential recovery journey. And we be mindful and attentive to what's happening in their lives regarding medical needs, social service needs, behavioral health needs, and importantly, potential pharmacologic treatments that may be beneficial for them. For those without an income or health insurance, access to these areas is essentially non-existent. And many times we send someone through rehab or help them achieve sobriety. If the rest of their life is in shambles or in need of serious attention and support, the rate they return to addictive patterns and behaviors remains very high. In focusing in on what we have to work with in providing treatment and recovery support to individuals with substance use disorders, we have 5 models really available to us. Step programs, medication-assisted treatment, or MAT, residences, a harm reduction approach to addiction and drug use, and support. So let's all just take a moment and we'll take a look at each one of these. Step program originated from Alcoholics Anonymous and our set of guidelines to help individuals recover from their addiction. Building one of the original founders of the AA program, recognized the need for an effective treatment program for individuals who are struggling. And in 1939, after battling with his own alcoholism for years and finally in recovery, he wrote the big book for Alcoholics Anonymous, which became the foundation for the 12-step program. These are open to anyone, and today there are a number of ways to participate, from in-person meetings to online groups. They are rarely abstinence-based, but are also becoming increasingly accepting of the idea of multiple pathways to recovery, including the use of medication-assisted treatment. One that has helped shift the 12-step perspective to accept multiple pathways approaches is that, while completely unintended by 12-step practitioners, the evidence-based philosophy may inadvertently have promoted additional discrimination and stigma for those unsuccessful in model. This failing mentality is slowly being replaced with the understanding that addiction is a brain disease, as Dr. has pointed out. And as such, like any disease, medication may be required to help treat it. Now, I want to be really clear here that my intent is not to disparage a 12-step program or even minimize their efficacy viability. The line here for me is that if just one person defined recovery through a 12-step program, well, then there's a viable pathway to recovery and it should be honored and embraced. 12-step programs are an incredibly important resource, both for our community and for individuals struggling with addiction challenges. Not a lot of time here on medication-assisted treatment, as Dr. Gray's presentation was comprehensive. But the model, we know, especially in today's opioid epidemic, that this treatment is a critical evidence-based approach to addressing opioid use disorders. We all know that through MAT, abstinence rates, exceed 60% in long-term follow-ups, something that would make any 12-step advocate cheer. And Craig also pointed out earlier, there are 3 medications available for those who are using MAT. As you see, these are the same medications Dr. Gray discussed, but I added the screenshot of a very important tool developed by the SAMHSA brass tacks team, highlighting the 3 medications available for MAT. This way you don't have to commit it all to your memory. This is Decisions in Recovery shared decision-making tool. It's available online right now. It's free of charge. And as we developed it, we knew a few things based on a lot of research. The tool would be practical. It had accessible for a wide audience. It needed to information and help people begin to think about making a change in their lives. It be available to a broad range of learners with language accessibility at around the 8th grade. And it needed to have a very simple framework. A multimedia user-directed website helps with opioid use disorder answer 3 principal questions. What is right for them in their recovery? If they're interested in pursuing, and then which of the 3 licensed MAT medications best meets their needs. And finally, how do you get started with MAT in collaboration with their medical provider? Their decision-making model to engage clients and providers that incorporates real-world video testimonial from people in recovery. Found to be critically important was truly thinking through how peers fit into the opioid use disorder epidemic. This tool is a natural roadmap for utilizing peer support recovery services. The recovery tool incorporates a number of recovery tools, including a set of worksheets that people can download, print, email to their peer specialist or provider. There is a level of introspection and deep consideration about defining a personal recovery path, and you access this tool at the web link at the bottom of this slide. And I strongly encourage you to take a look and share this tool with your colleagues and any key stakeholders. Provide safe and healthy housing with an eye towards either initiating or sustaining the individual's recovery journey. In 2011, the National Alliance for Recovery Residences, or NAR, established a national standard for recovery residences. They define the spectrum of recovery-oriented housing and services. Distinguishes 4 different types, which are levels or levels of support. The state developed a strength-based and collaborative approach that solicited input from all major regional, national recovery housing organizations. Guidance was also received from recovery residence providers from across the nation. And they have noticed that from the slide that recovery residences are abstinence-based models. I want to point out a very important caveat they share about this. It is abstinence from alcohol and other non-prescribed drug use. This is a critical distinction that has opened the doors for individuals using medication-assisted treatment to access recovery residences. Now, recovery residences are doing this currently, but if we do believe in multiple pathways and no wrong doors to the recovery journey, we must continue to promote NAR's approach here as a viable recovery vehicle for anyone interested in pursuing their recovery. Coalition defines harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And Dr. Gray talked a little bit about this. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. Harm incorporates a spectrum of strategies from safer use to managed use, abstinence to meet drug users where they're at, conditions of use along with the use itself. Harm reduction demands that interventions and policies designed to serve drug users reflect specific individual and community needs. There is no universal definition or formula for implementing harm reduction. In implementing this approach, the Harm Reduction Coalition considers another principle central to harm reduction practice. I won't cover them all at this point, but there is a downloadable document that will address every one of those. Strategies are shown here in a really simple and concise way. For instance, clean syringes and opioid overdose prevention with naloxone trainings are very, very good examples. For the methadone clinics and buprenorphine prescribers are good examples. And for Good Samaritan laws made for a methadone clinic in every county in the country, licensing buprenorphine physicians, these are all examples of harm reduction policies. Studies that demonstrate the effectiveness and efficacy of peer support. For example, it was demonstrated that peer support helps improve the mental health of veterans, make people reduce hospital visits for those with co-occurring disorders, and coping skills of family member who has a serious mental illness or a substance use disorder. SAMHSA, the Department of Veterans Affairs, and 40 states consider peer and family support an evidence-based practice. Peer services usually operate in conjunction with clinical services, which amplify the benefit of treatment by engaging peers in services individuals might otherwise not accept, offering support and psychosocial rehabilitation, and engaging peers to stay in treatment and services by sharing their stories of recovery. Support services require that they be part of a treatment plan authorized by a licensed practitioner of the healing arts, such as a psychiatrist, a psychologist, or a physician, in order to be reimbursed by Medicaid under the Centers for Medicaid and Medicaid Services rules. Peer support services are a valuable adjunct to traditional care that are to contribute to improved outcomes in employment, education, housing ability, satisfaction, self-esteem, medication adherence, and a decrease in the need for more costly services, hospitalizations. Peer provided services help to foster recovery, increase and service engagement, reduce acute care costs and use, and improve the overall quality of life. So, what workers care about any of this? Well, this information helps us look beyond the deficit, the what's wrong with you approach, and recognizes the importance of income, insurance, and peers in supporting the whole person. It helps identify both the issues for SOAR filing, and it provides a framework for ancillary recovery support for the individual upon receipt of the new benefits. Now, insurance allows access to treatment for a host of challenges and issues related and unrelated to drug use, all related to a satisfying and productive life in the community. Provides funding for housing, residences, and critical resources like transportation, food, medications, health needs, dental care, and other things like that. Peer wellness and recovery via lived experience and modeling a powerful recovery force for those who are still struggling in active addiction, and also act as a gateway between the clinician and the client. Let me tell you all why this information is important to me. It's personal, and I'm a person in long-term recovery as a result of most of these treatment approaches. I was and I have a long history of long-term heroin and cocaine use, almost 30 years. I then spent years in a medication-assisted treatment program and detoxed out of that program under medical supervision on February 13, 2014. I'm sober the past 3 years now, for the first time since I was a teenager. For my recovery coaches and 12-step proponents, I understand the discrimination I experienced from 12-step program stigma because I could not achieve abstinence back in the 1990s. It actually laid my entry into medication-assisted treatment 3 years, and in those 3 years, I overdosed 3 times. All 3 of those were reversed by Narcan. What I want folks to understand is that this wasn't a malicious effort, but it was my brothers and sisters in the program who were trying to save my life the only way they knew how at the time. Now, through education and awareness, programs have begun to understand that that is a viable pathway to recovery. Clean syringes, info on drug interactions like benzos and opioids, speed balls, all things I was doing on the MAP program in my community, and this information protected me from serious diseases, and it all provided me with another recovery pathway through medication-assisted treatment. A system of approach focused on my whole health wellness when I was still focused on my substance misuse. And it helped think about my life in terms of the impact of trauma, as well as the critical importance of stability and support in the areas of health, home, community, and my own purpose. Here's the critical component that made detox from medication-assisted treatment possible, and then supported me through 2 years of pretty intense post-acute withdrawal syndrome, or PAWS. I could not have done this without that support. While I was in the MAP program, I did a bachelor's, a master's degree, and all while practicing holistic wellness approaches. I'm proud to say that this is the best job I've ever held, the longest relationship of my life with a supporting, loving, and healthy partner. I've reunified with a family that was fractured and scattered as a result of my drug use and my incarceration. I own home. I don't have to worry about homelessness again. And I attention now to primary care, behavioral health, and dental health. Fine. It seems like a lifetime of struggle. Today, at 58 years old, I have a thriving life in my community and a productive member of that community as well. So here's one as I close this presentation. I realize how challenging it is for many of you to see difficult clients day after day and not feel somehow that some of us are never going to change. Please, I'm imploring you, never give up on any of us. Many who gave up on me, and who did not, I owe their life and everything I have today. It should not just be something we talk about. It's expected, and SOAR can be a major stepping stone along the recovery pathway. SOAR can provide the keys, literally and figuratively, and the opportunity to pursue many other options leading to supporting a full recovery and ultimately that satisfying and productive life in our communities. It's what we want for every single person we're working with today. So for your time today, thanks again to SAMHSA and the Policy Research Associates for the opportunity to share, and I hope you all have a terrific afternoon. Pam?
Thanks, Stephen, so much for your very powerful presentation and sharing your personal story. And again, congratulations on your recovery, your continued recovery. You provide so much hope and inspiration to others. So now it's time to open it up to questions and answers. To be able to ask a question or make a comment, you can type your question into the Q&A panel, which is located underneath the participant tab on the right-hand side of your screen. So you can, again, use that to type in some questions. We do have some questions that came in already. And again, I'm going to start with this question. And Steve, you may have just answered it. But again, I think it's so important for you to hit this home again. We want to make sure that folks really, understand your message here. Let me just pull it up for you. It had to do with an individual who's been on methadone for a little over 20 years, but really the manager or the individual has not seen any semblance of recovery with the individual. And you might need more information, more to this question, but Steve, would you want to kind of talk a little bit about that, an individual who's been on methadone for 20 years, but yet not seeing that this is somebody that is recovered, recovery tool?
And thank you for that. There's additional information that I certainly would ask about, but if I was to dig deeper into this, but I think off the top of my head, what I can say is this. The drug methadone or buprenorphine, I always think of that as treatment, right? That is the treatment that we receive for opioid use disorder. Recovery is the information that we collect as the support, the social capital, the things that we pull into our lives that are supportive of our recovery journey. Now, when I first started the methadone program for about 5 years, I thought of methadone as treatment, and I also thought of it as recovery, and I hadn't really been exposed to recovery language and principles. I think that piece often is lacking in a lot of the treatment modalities or treatment protocols that, particularly through clinics, we get them from counselors, within the methadone clinic itself. But I think where the real strength of the recovery message comes is from a counselor at a methadone clinic. It is from a person like Stephen Samra, who has been in a methadone program, has recovered, and who walks alongside another individual on their recovery journey, sharing, our recovery, key points of our recovery story, exposing them to recovery literature and recovery principles. And in order for us to get there, our counselors need to have, at least a base in understanding what peer recovery principles are.
Stephen, now do you think this is an individual who may not have been connected to a peer support specialist, someone like yourself then?
It's highly likely. It's hard to guess, but it wouldn't surprise me to hear that they've been working through the clinic, attending meetings at the clinic, meeting with their counselor, and the various meetings that are required as for participation in a MAT program. But even in that environment, the understanding of particularly peer recovery principles is pretty limited, and this is not their fault. There's an onus on the peer recovery world to collaborate and work alongside clinicians, to really strengthen that knowledge and to model our own recovery, both to individuals who may still be in a program and to the clinicians themselves. The other thing I'll add about this really quickly is that 20 years in the program, I spent 15 years in. I never had an indicator for myself that I wanted to come off until I felt like I had reached the point, particularly my work, that I thought I could do more. And I after spending 4 decades under the influence of some, really wanted to know what life was like sober. I just wanted that really bad. I share that because not everybody is going to come off of this program. Some people may spend a lifetime on it. But the bottom line is, when you think about this in terms of harm reduction, I'd much rather see somebody in the program for their lifetime rather than exiting out with the potential to relapse and all the harm that can come from that.
Mm-hmm. Thanks, Steve. Maybe.
This is Dr. Gray. I just wanted to chime in as well. This is a situation that I hear about sometimes as well. And I think the couple of things I wanted to add were, one, when you think about one of the principles of a harm reduction approach is to meet the patient where they are, meet the client where they are. So the other thing is that while Stephen, that was a really incredible story, and obviously what recovery has meant for you is really wonderful. Recovery is going to mean something different to everyone. So I think sometimes our job can just be to say to someone, you can just point out and say, hey, it seems like you're a bit stuck or not reaching your goals. And you can just say, tell me what your goals are with your life, with your work, with something, and let the patient drive what they have to happen with their lives. And then if it turns out the treatment's getting in the way, great, we deal with that. And otherwise they continue the treatment. So I think that place is to start. Just let the patient define kind of where they want to go and what their recovery looks like to them.
Mm-hmm. Dr. Gray, and next week, one of our panelists will be talking about some motivational interviewing techniques on certainly how to help a person get unstuck and sharing some of those, some of those principles, techniques next week. So I think that's a great idea. Here's another question that we have, and this could be for Dr. Gray. Stephen, how long does a detox take for, say, heroin? They said. How long does a detox take for a heroin, for example? Maybe, again, individual. Dr. Gray, do you want to take that? Just...
Sure. It's a bit tough to answer. So detox process is going to differ depending on the substance, and a lot of it has to do with the chemical properties of how long these things stay in your body. So for heroin, for example, heroin actually gets out of the system pretty quickly. So for most people, a heroin detox would average about a week. Some programs would do a 2-week detox. You can do detoxing as quick as 2 or 3 days. It really depends on there's different medical strategies for detoxing, and that will dictate how long that process is. The main reason I think about detox is for alcohol, so that sometimes it's days or many days long. But again, it's quite specific to the substance. But 2 weeks or longer would be on the long end of a detox.
Okay. Question that came in. You talk a little bit about the challenges of prescribing and the overprescribing of opioids and how this may lead over time to accessing street drugs. One of the theories for why this opiate epidemic is kind of rampant now, Jackie touched on this a little bit, that there are areas in the country where there is such a high rate of opiate prescriptions, and about that is, in person or given population, if there's an increased exposure to opiates, there's a good chance that some people's brains are triggered into developing an addictive response to that drug, which would then lead them down a pathway towards developing an opiate use disorder. So it's kind of like, just by the sheer exposure to people, the number of pills around, you're just more likely to have that happen. And a common scenario that we're seeing is, especially in the kind of more recent epidemic, is that people are starting off, either whether it's pills prescribed to them or a friend, they start out with pain pills, they then start crushing and snorting them, maybe injecting them, and at some point they realize that, there's some money on these pills and heroin's a heck of a lot cheaper. So that's a transition that happens for a lot of people. It's by no means universal. But I think that's one way that I see these two being connected. Okay. Part is, are we addressing this as part of the strategy in combating opioid use disorder?
That's a good question. I'm not sure I'm the authority to answer that, but there certainly is action from a lot of different levels, from I can't speak to the federal policies, but certainly the state has their own kind of governance of providers and prescribing, and a big part of it is information sharing. So here in Maryland, like I'm sure in a lot of states, I can log into a website and the patient's information and see any prescriptions they filled for controlled medications. Ours actually includes our neighboring states as well. And so we're working on information sharing. There are checks and balances with pharmacies, and it's a challenge, but I'm not sure I'm prepared to speak to kind of all levels of intervention that's happened, but it is attempting to be. It's trying to.
Go ahead. Head on.
Yeah, two quick comments. One, backing up around the detox piece. Yeah, Dr. Gray's spot on. And one of the things that I would point out around detox, particularly for folks who, suffer from OUD, opioid use disorder, we're really used to going through cycles of well, sick, and detoxing. That is a pretty normal, common experience for all of us, and it happens a lot. And I never had the fear around, the actual detox itself. And, I detoxed off of heroin a number of times. Certainly detoxing off of methadone was more challenging. But the one point I want to make and share with the the participants on this event is that it wasn't the acute detox that was the biggest challenge for me, and what became a big challenge was the post-acute detox or withdrawal syndrome or symptoms, excuse me, that I began experiencing about 90 days after I had completed the acute detox. And that's something that I think the clinics are missing, and we providers and peer support specialists are also missing. And it's a really important piece because I would think that, certainly in my own case, I suspect that reason, that experiencing post-acute withdrawal and not understanding what was going on months after I had detoxed off of heroin led me to relapse. This idea of pause, I think, is really, really important, and it's something that I think we need to, all get up to speed a little better on. A second thing I'll say is, Dr. Gray, again, is spot on. I started my opioid, sort of excursion with a bottle of Tussonex cough syrup when I was 14, and I used pills for as long as I could get them. But when they became too expensive and when I was cut off from the pill supply, when I ventured into the street, and when at the moment I found heroin, I at first, the pills didn't have the impact that the heroin did. I was freed from the hassle of trying to do that through a doctor, and all of those things were really appealing at the height of my addiction. So I just wanted to share that. Thank you.
Great, much. Here's a question that came in. Are there recovery residences that are managed and operated by peer specialist organizations? Even for that.
So there are some PROs, peer-run organizations out there that I think are, certainly, managing recovery residences. They're more on the recovery coach side versus the mental health peer support side. It's just a, kind of an internal distinction between the two fields. And you can think about that in terms of, places like Oxford houses. There may be some organizations that are, supporting the work of Oxford houses, even though those are independent level 1 recovery residences. There's still some PROs or RCOs, recovery community organizations out there, and that's the more appropriate term, that are handling that. And one of the greatest pieces of information that NAR provides is information around the national recovery resident scope and what's going on within recovery community organizations and their support of those residents.
Thank you. Question: what can we do for someone who refuses to get the help they need, admits they have a problem, and has overdosed twice, and still seeks to use? I know from experience this person used immediately after being released from hospital after an overdose. And I know it's there's a lot in that question to unpack, so I'm going to throw that to really any of the panelists who has seen this and provide some brief advice.
So, Stephen, and I'll just say this, don't give up. You don't know what word, what phrase, the time of day when you approach that individual. You may catch them at a point where, finally they're like, I can't do this anymore. I just can't. It took me 7 years from the point that I first began to be contemplative of my recovery before I actually entered recovery. And in 7 years, I overdosed 3 times. I'm certainly lucky to be here today. But my bottom line, you can never give up on anybody. You just have to keep putting the information in front of them. You want to do that in a strengths-based, positive, supportive way, but respecting the dignity of the individual, of the human being in front of you, and recognizing that they have a serious health condition, right? I mean, they've got a brain disease. They're suffering from the disease of addiction. Please never give up.
Thank you so much for those, really the parting words today. We are out of time, and we want to thank presenters for sharing such excellent and helpful information. And again, if we didn't get to your question, and we know we had many, we will post them to the panelists for follow-up after the webinar. And we did have some questions related to the Social Security Administration and filing SOAR applications. And again, we'll make sure that those questions are presented to our Social Security folks who will be on the next week. So again, a reminder, our second webinar is next Wednesday, October 25th at the same time, and we'll be continuing the conversation on opioids and other drug usage, treatment, and again, SSA policy on this area. And again, when you log out, you'll be taken right to an evaluation. We really ask that you complete that because it informs our future webinar topics. Again, thank you again, and look for the slides and the other handouts to be available on the website, the recording next week. So again, thanks so much, and enjoy the rest of your afternoon.